get started. I know there's a few more people that are coming, so they should just filter in as they come. I'm Chris Perky. This is Denise Walsh. We are from RSNF. We also have Sarah Harney, who's from RSNF, and she's going to be recording this today. We weren't sure what the venue was going to be like, what the acoustics are going to be like. That's why we didn't want to do a live webinar. But what we decided to do was to record it, so hopefully, if we're lucky, it will come out okay. We also have some DHMH here. Do you want to stand? So if you have any questions, she's been very helpful in setting everything up for today. She works without the hat. So a little housekeeping things to get started. First of all, the bathrooms, which most of you probably already know, go right across here on the right. And they do have like a canteen with vending machine, which is straight across. What we're going to try to do is go for maybe an hour and then have a 15-minute break or so you can move around. We may break a little bit sooner or later depending on where we're at on the manual. We broke the sections down into each one of the departments, tried to marry the sections that were the most likely to be done together. We know that some of the health departments have their STI mixed in with their family planning. They don't have a separate. Some people have a separate STI program, some have a separate HIV program, some don't have any at all. So what we wanted to do was try to put those life programs together. So at the end of the session, when we start talking about telemedicine and dental, which we're not really going to go into real deep on, you may want to leave at that point. It may not be applicable to you or your health department. So that's the reason why we try to set it up that way, because we know this is a long day. So with that, today we started with version 3. I worked on it yesterday, updated a lot of information in the manual. And so we're on version 3, the date's 5/24, today's date. If there's anything that comes out of today, I'll add it to it. But other than that, this will be the final version at this point. It's not loaded onto the DHMH website yet, but it will be loaded on after the session's over. We'll make sure that's taken care of. And any recording from this session today, just like the other webinars. So does anybody, who attended the last webinars? Did anybody attend any of them? Okay. Because I just didn't know, I want to show you a little bit about navigating around through through the manual. Denise, let's give a little bit of introductions too, by the way. Denise, you want to introduce why we brought in today?
Hi.
Here you go.
Thank you. Usually I don't need a microphone because I'm usually fairly loud, but anyway. So I'm coding and compliance for RSNF. So most of you, or some of you, have already worked with your health departments doing chart audits, E&M training for your providers. And for those of you that I haven't met, well, it's nice to see you today. What I'm here for today is just as an extra resource. So as we are going through each section of the manual, and if coding questions come up or maybe possibly some billing questions, I'm here as a resource to ask any questions. If there are things that I can't answer for you, we will definitely get back to you. Give me your email address, and we will be able to respond to you after the fact. But hopefully today we're going to go through these sections. It's not going to be a coding and billing training class. We are just going to highlight each section, tell you what the tools are, where you can find these references. But if something does come up, I'm here as a resource, and hopefully I'll be able to help you today.
So during the webinars, the first webinar, we hit chapters 1, 2, 3, 5, and then after that we hit 6 all the way through to the end of the manual. But today we're going to hit chapter 4, and we decided to do a live on-site training. That way we could, respond and do questions and, more of an interactive type session than it is when you're sitting in a webinar staring at a wall trying to see whether everybody gets it or not. So, but first of all, we will show you how to navigate through the webinar, through the manual. Stay with me, I get a little nervous. We loaded in Adobe Portfolio, and the reason why we decided to do it in this format, because it's so huge that, and paper is just, everybody's trying to do it paperless. The other thing is you're going to be able to search. You're going to be able to navigate through it, and this is the manual can be updated as it needs to be. So all you need to get access to the manual is written on those little strips of paper that we have attached to those big dollar bills. Okay, so that is the access. If you have any trouble, you can get in touch with us or DHMH, and they'll let you know. So this is the cover page, obviously, and when you see this, if you double click it, it brings it up here. Anything that you see within the manual, you can download and you can save it. It will open it up, and then you can view it and save it yourself. It will not change for everybody else. It will just be something you can keep on your desktop. You can save the entire manual if you want to. I don't advise that you really necessarily want to do that. You want to make sure you have the most current version in front of you, so it's really easy just to have an icon or something and click on it and then be able to have access to it. We also put a lot of hyperlinks within the manual so that you could click on it and go right to the website. The reason why is we knew a lot of the information changes on a regular basis. We want you to have the access to be able to get that information, updated information, not just within here. And we'll show you how to use that.
Have most of you logged onto the site yet and have looked onto the manual and had access to it? So, okay.
You feel comfortable? We thought it was pretty intuitive type program, so. When you click on the search bar, you can type in something like CLIA or COMAR or IV for immunizations, and what it will do is pull up all those documents, up to 50 documents in there, so you can click on it. So I'm going to click on here. You can see this little bar going around. It's searching for the documents within the whole manual, and you can see how it's bringing up anything to do with COMAR. So you can actually go down and look. So if you see something that you have that you want to look at, you can do it this way. It's really a simple way to, because it's so massive. What we've been recommending that you do is also print out the table of contents. Okay. So if you come up the table of contents and have that with you, then you also know where you want to go within the manual because it's so massive. This is a typical disclaimer that we have, just let you know that who you can reach, which is now Sabrina, if you have any questions about the manual. But this also lets you know that everything that we put in here was up to date when we did, and that we're not saying we're attorneys or accountants or anything like that. We've got resources, and this is what the disclaimer is basically saying, that we pull from resources. This is just a little bit about why the manual was created. And this tells you about the Adobe Portfolio, which is this format. So that if you lose your little piece of paper and you get in here, you can see a little bit about why we chose this venue to do it. And then here's navigating around the portfolio. So this shows you all those quick access. We had this in the other webinars. We started each one of them the same thing. So if you print out these sheets, it'll show you again how to do the search button, what it looks like. And how we have here explains each one of the chapters and what it looks like inside. So I won't dwell too much on information on that because we've done that with each webinar, but it is right at the beginning of the manual. This is the table of contents. And you can see our first chapter is general information about the state of Maryland, about the counties and the governance, because some of you are under certain restrictions because you have county regulations. You have to go through a board, or you may have to go through your financial people in order to have any of your policies and procedures or even contracting done. So that's the reason why we did a little bit of an introduction with that section. Creating the billing foundation. Here we go into a little bit about COMAR regulations and non-chargeable lists, which obviously may change July 1st. That's what we're saying. This needs to be updated randomly. deciding fee scale, poverty levels, a little bit about, what you have to have, CLIA numbers to get paid for lab tests and things like that. So this gives you information on how to obtain that information, why you need it for billing. This section on the revenue cycle goes through each piece of the revenue cycle, which starts from the moment the patient contacts you, whether it's at the time that they're having an appointment or whether it's the time they walk in. Starts from that moment until the entire encounter, until you've gotten paid. So this section actually does a deep dive into each part of the revenue cycle. And today we're going to talk about the programs. We also had discussion about the second webinar on the billing-related software, talking about your practice management systems, clearinghouses, electronic medical records, health records, and patient provider portals. The Maryland payers, I updated a lot of the information in that yesterday. We talked about Medicaid, their rules and regulations. We talked about Medicare, because they're different. Some of the health departments are participating now with Medicare. We go into commercial payers. And we also have most of the provider manuals. We tried to update as many as we could with 2017 if they have it. And of course with the MCOs. Contracting and credentialing, that's been a big issue. We're starting to see more and more of the health departments getting contracted with the payers, which is extremely important for reimbursement issues. And this talks also about how to credential through CAQH. This is a little bit about compliance. DHMH does have our own compliance plan. We do have that in here, the information, the OIG, about the Federal Register compliance programs, and a little bit about HIPAA access tracking. We found so many times that we go to practices and also the health department that people have access to different software, have access to online portals with the payers. But when somebody leaves, they don't always disconnect all those. So for HIPAA purposes, you need to know and you need to track what employee has access to what, and you need to make sure that it's deactivated when they're no longer employed there. So that's a tracking sheet that we put in there, just a kind of a little tickler to let you know what you need to track. And then these are resources. I added a lot more to it yesterday, just extra resources. Some of the resources are found within the manual in the different sections, but I thought it was important enough with some of them to pull them out and to have them in this section too. We're going to skip over all the chapters until we get to chapter 4, which is this one. And this is all the different programs within the health department. So the first one we're going to talk about today is the HIV program. Now each one of the sections that we have with the programs, we tried to do an introduction. And the introduction sheet usually will explain if it's something that's on the non-chargeable list. That may affect your billing, what you're allowed to bill and what you're not allowed to bill. Then as something like HIV, you're allowed to bill a self-referral for the DES services, diagnostic and evaluation service, if you don't have to be contracted with the MCOs in order to get paid for that service, but you do have to call them to get authorization. So what we've done, this is what we were talking about, the hyperlink. I click on that, takes us right to the resource. So what is a managed care organization? It links you to all the information that we're referring to. So sometimes we don't go into a lot of detail because we have the link right there for you. Now, one of the things that Denise and I want to do is introduce everything for you today, but we don't want to spend a lot of time going into a lot of detail about every single thing that's in, because it's not really a training session for training how to bill for different programs. It's an introduction, so you'll know how to navigate around and be able to get access to what you want out of the manual, and especially because some of you may not be involved in each program. Please, if you have any questions, we'll open the questions also. We'd love to have some feedback. It's interactive. Okay? We also included memos from DHMH. And this is talking about the Ryan White program. And again, we put things in here that we thought were pertinent to billing today. And this is also talking about the case management services, which you go into also in the manual for HIV. That's another self-referral service is the case management. We also show the codes. Let me show it here. It shows the codes, shows how many units, and shows what the rate is. And what you have to do in order to get paid. One other thing here, if you go, see the arrow, if you point down, it will take you to the second page. Some of these, this is one reason why we wanted to use this form also for the manual, because some of these manuals that are in here from the MCOs and from even DHMH may have 100 pages to it. You don't want to download the whole thing. There might just be certain things that you don't want to print the whole thing. You might want to download it and just save certain sections of it, and that's the reason why we put that in there too. This little I button, we put in some information here. This is like a little tag that you can put in. I'm trying to put in every time I've made an update or a change. Like yesterday, I put in there added to such and such date, because as you go from one version to the next, you don't know whether something's been added or not. I also I do delete what's old information, so if we have a more updated, like the comparison chart for the MCOs, that gets updated on a regular basis. When it's updated, it gets put in there, and we take the old one out. This is a little bit about time-based coding. I'm going to let Denise mention a little bit about this. And the reason why we do for HIV, because a lot of times your HIV and STI services are not as much a review of systems as it is counseling.
Again, not to go into a whole coding training, but the reason that this is in here is because for any type of counseling services that you may do, time-based coding may be more beneficial to the providers than looking at a regular E&M and looking at all of the components, history, exam, medical decision-making. A lot of times these E&M visits are based on time because the provider is doing more counseling for the patient. So we've listed the requirements for time-based coding, and that may be, again, that may be beneficial. It's a good resource for you and for your providers for billing E&M services for HIV, STI as well. Any type of services where you are doing counseling, educating, coordination of care, time-based coding may be beneficial, may be more beneficial than looking at the E&M components.
Thing is, you always have to document the start and end times. How long?
So if you're going to use time-based coding, again, the document spells everything out for you, but you need to make sure that you have met all the requirements. So time-based coding basically is saying that this is a face-to-face encounter with the patient, that over 50% of your time for that visit was spent counseling, educating, coordination of care, and that this time that you documented the total time, your start, your stop time, and again, that 50% of that total time was spent counseling. Then you can use time as your basis for billing your E&M visit. Again, this type of billing may be more beneficial when dealing with these types of patients.
This is just a sample super bill. Again, it's a sample. Try to keep it updated to be the most updated codes, for the manual.
The codes do change annually. That doesn't mean that these will, but every year they come out with new codes, added codes, deleted codes. So it's always a good idea to check your super bill on a regular basis. They will give these updates usually in October. They go in effect in January. And again, the new updates, they're not always relevant to you, but they do have changes every year. So I recommend that you look at your super bill, look at the diagnosis codes that you're using, look at the CPT codes that you're using, and just verify that they are current every year.
If you're using your computer and also have a paper super bill, I've seen it that the paper super bill gets updated, but it doesn't get updated in the program. Okay, and if you don't have a paper super bill, or piece of accounting form, whatever you want to call it, then what you might want to do is print it out from your software, and then that way you can double check your codes. A prime example is like the HPV vaccine. There's been the third code has just come out last year, and a lot of people hadn't updated that. Depo-Provera, even though that changed several years ago, that didn't get updated with a lot of health departments. And as of last Monday, the 15th, they had new codes for SUD, for substance use disorders that they implemented, and that was right in the middle of May. So, you know, things do change. Of course, with your program, yours should be more in tune to what's happening with your program, your codes. You won't be in tune maybe with, you know, another program but yours. Most of your payers will have updates that you can sign up for with them to get their newsletters. I really advise everybody to sign up for that. Even if you're non-participating, keep an eye on that, because the trend is that everybody's going to be participating with at least all the NCOs in the near future. This is just a CPT documentation guide for outpatient HIV care. Again, it's another resource that we were able to get, and we've included that in the manual for you.
I love this. So it is a great cheat sheet, not only for HIV, but honestly, it has all the information for your providers. Kind of gives you just little bullet points for E&M coding. So it's a good reference, whether you're billing a new patient, an established patient, whether this is a consult, or whether you're doing whatever it might be, a physical preventive care. This gives you all of the necessary requirements. It's a nice little document that honestly you could either laminate or you could trifold, but it's a good reference tool for your providers to be able to see, you know, what elements are necessary for a level 1 visit, level 2, level 3, level 4. So I think it's a really good cheat sheet for providers, not just HIV, but all for all internal medicine, primary care.
Now this is another billing and coding guide for HIV prevention. You can see it's a whole manual and gives you the overview. Again, it's got here, it doesn't say how many pages, 37 pages. So you can download the whole manual if you want to, or again, you can just do sections of it. So we thought this goes into more about the prep and the screening and services linkage. Here's another one, coding concepts. Gives you the ICD-10 codes. Now we talked a little bit before in some of the other webinars about that online coding search tool. That's also in the resources. A lot of the software now that you may have automatically has that all uploaded, so you can do your own search within the practice management system. But we know there are still a lot of health departments that don't have a practice management system, at least one that doesn't pull over those ICD-10 codes. And those have changed. They keep changing.
They do keep changing. They keep adding codes every year.
Again, this is more issues about billing and reimbursement, another resource. The reason I included this one with Texas, the Cardia, we did some talks with them with STI and HIV a few years ago, and Cardia has some excellent resources, and they were fine about us using it in any way we wanted to, because they want everybody to be able to bill good, you know, and collect, because they know the problems that, you know, all the health departments are having. So they have, you know, this is an excellent tool, and they go into all the different problems that you're going to run. Again, they have the specific codes again. This is a couple years old, so some of the codes may have been updated, but for the most part, most of these are still valid and good codes to use. We can't emphasize enough as the payers are starting to get more specific with what they want in the codes to make sure you have enough digits in it, not to be using non-specific codes. Denise is seeing that.
With ICD-10, and I'm sure now we've all had a year or so to start using ICD-10, one of the biggest things with ICD-10 was specificity and making sure that you are using or you code to the highest level of specificity. In some cases, that may not be possible. So to say that you can totally eliminate the unspecified codes is an unrealistic statement. You're still going to use them. What they want to get rid of is using, before ICD-10 went into place, 70% of all codes that were submitted to Medicare, CMS, Medicare and Medicaid, were unspecified. So, for most providers, I've always heard, it's just easier. It's just easier. That used to be the 0.9 with unspecified. So now they're like, we're giving you these options. We're giving you the detail. We want to know for so many reasons that we won't get into. But, so providers still have a tendency, whether it be the access, the toggling through their practice management system, their EMR, looking for the right codes, or just have it. They do a lot of unspecified. So what we want to get from you is making sure if you know the etiology, if you know the cause, the manifestation, that you are using those specified codes. When, I always give the example, abdominal pain, if documentation states left lower quadrant pain, make sure that's what you're coding, not the first that comes up, which is abdominal pain unspecified. Those are the kinds of things. If the patient says, I've got pain all over, it should be more generalized or localized. So when there's a better code to use, it should be used, especially when you're talking about extremities or you're talking about, anatomy, localization. So, make sure when we are doing these when you're doing ICD-10s that you are looking at them, your providers are using the highest level of specificity, and it will help to get the claims paid quicker, faster. It will eliminate claims coming back, asking for more information, more or possibly medical records for them. So just to keep that in mind. But it is impossible to eliminate the unspecified codes, just to reduce them as much as we possibly can.
Some of the little robust practice management systems will actually, if you try to use a code that is not specified enough, it'll let you know and give you other options, which is extremely important, like we said. Now this slide's about the 340. This is just a little information about 340B direct pricing program. We found a lot of times with in HIV clinics, they may be giving medications out to the patients, especially if they come in and have an STI or something like that, and they want to make sure they get their medications. They don't go back out into the public and get somebody asks chlamydia or something. So they purchase some of their drugs through the 340B program. So this is just some information. If you're billing for any of your drugs that you get through the 340B to Medicaid or Medicare, you can only charge the acquisition cost. This is just a little bit that gives you a little bit of information about that as a guide. Again, this is another memo that we thought was important about HIV in the background, and also some links. Then I did a subfolder for Ryan White. A lot of people have questions about the Ryan White, what their program is, what they, what the parameters are within the program. So that's the reason we included a separate folder for that. And again, these documents are as up to date as we could find. Are there any questions about the HIV folder or chapter? Again, our main goal today is to make sure you know what's in there so you know how to get information that you may need. We put a folder in here about PrEP. PrEP is for the prophylactic high-risk patients that are exposed to possibly HIV. It's not something that you can bill for dispensing. Usually you have a prescription, But some of the criteria with your MCOs about filling out the form so that they can get the medication, that's the reason why we included this here. Plus, you know, if you see a patient and they're getting the prophylactic meds and you're writing the prescriptions, you can still bill for the E&M services. So that's the reason why we wanted to mention it too. But it really goes hand in hand with the HIV and some of the STI programs. So again, if you click the link, oops, that one's not the one that's getting there because of being here.
Yeah.
Again, more information about PrEP.
Can we ask a question?
Please.
A lot of our HIV clients, we did a hardship years ago, and I know now our health officer was instructed to stop the hardship. And I see our supervisor told us that there was a waiver and co-pays, but it was nothing like the hardship, because hardship was like therapeutic or financial, so they would bring in like lots of doctor's bills and we would put it together, then the health officer could put a percent that they could pay or just an amount. But we're not seeing that in this, and we wanted to know where that stands at.
Okay, now one of the things that one of the earlier chapters when we talked about, we had the COMO regulation that talks about that the health officers have the discretion as to whether they want, feel that it's in the best interest of their community for reasons they can write a waiver. A lot of the school-based health systems, they have wellness centers. They've written waivers so that they only bill Medicaid, self-pay, or payers. They don't have to bill the patients because it's not, their population, and they gave, people, usually the health officers give a whole list of reasons why. When it comes to hardship, what it's saying with the co-pays and all, you can't really have a general rule saying everybody that comes in, unless they're, if they're, you've got the sliding fee scale so you can judge, okay.
The hardship is supposed to be on a case-by-case basis.
Exactly, and that's how it used to be.
Yeah.
But then apparently they got away from that years ago, and the health officers were told they weren't allowed to do those. So now we wanted to know where it stands at now, because we do have clients that have substantial bills, even on the sliding scale, and they just can't afford it. I mean, unfortunately, they got to do a lot of
I
doctors.
have the OIG information in here on about hardship and all, and you can do the hardship on a case-by-case basis. You just can't say.
My understanding is still it is up to each individual, not medical director,
The health
officer. Yeah, it's still up to each individual health officer. As long as you don't have that blanket statement, that's what's not allowed to have is the blanket statement. You are looking at that. You have the sliding fee schedule in place, and you are looking at each case on a case-to-case basis. Then, that is the, his prerogative to eliminate the patient debt, patient responsibility. But it can't be. That's what they want to eliminate, is that blanket statement that it's just a hardship. Each individual case has to be looked at.
Okay. So does that provide an insurance contract that says your contract is the same cost, and you have to cost, and I think I read in there somewhere that you have to abide by the contract and please the code rates. But the health officers should override that then?
It can, yes.
Okay.
It can. The other thing is that they do have contracts with Blue Shield or any of their payers. But then if you go into somebody that's Title 10 and you submit it to the insurance company, and the insurance company says, oh, their copay is $50 or their co-insurance, and they're on the sliding fee scale and they're saying they really only need to pay $5 because of the Title 10 program, you only charge them $5. So some of this is where it gets so particular. It depends on whether you're under some other grant and funding restrictions. So and that's one reason for breaking it down. It's like when we get into reproductive health, we do have a little bit of information in there about Title X, because a lot of the health departments are using Title X funding. This has Ryan White funding. They're the last payer of resort, and that's why we included the section on Ryan White. We didn't want to go into detail about all the nuances and what we have to do. Most of the insurance health departments have known and understand it. We wanted to make sure that resource was there so that you could go back if you're questioning it. Because a lot of times you bring new employees in and people are talking about, like, I can't remember, what were we supposed to do with this because it's Ryan White, you know, and they do change. I went and did some research yesterday, and there's some updated articles in there, because each year the government, you know, how they're going to allocate money and that type of thing can change. So, but yeah, the hardship thing
right,
is,
and your contracts with the payers. I mean, so here's where it gets a little sticky. Is what they want to make sure that you're doing is not just immediately writing off that copay or saying, you know, we don't bill copay for these patients. So you are contracted. You have a contractual agreement with the payers to charge the patient a copay. Now, you know, that copay after, you know, bills can, you know, accrue, you know, and so that's when, again, you're looking at this on an individual case basis. So as long as, again, there's not a blanket statement that, you know, we don't charge these patients copays, you know, that's what they want to make sure that you are abiding by your contractual agreement with them, that you have charged them a copay. You know, what happens after the fact and when you're looking at the patient's bill and it becomes a hardship, then, you know, that's another circumstance.
where you run into problems is if there was an audit and they saw a pattern. You know, chances of that happening are kind of slim. But, you know, so I think one of the best things to do is to have policy and procedures. Harford County has great policy and procedures, and, you know, in place. I've looked at theirs and some of the other counties. And what it does is it says, okay, this is what we do in this case. You know, hardship bill, stress hardship maybe. The hardship is going to say it's on an individual basis. Again, so that's covering you to say that that's what your policy is and that's how you follow through the things. So you would almost need it with, because you have so many different funding sources and all, you have to address some of those depending specific to those programs. Okay? Yes?
Someone was saying advertise that to
It depends on the program. The sliding fee scale is applied typically in most of the health departments and, you know, community service clinics based on income and based on patient, you know, how many family members they are. Okay, but if you're in like family planning and Title X funding, they're saying that whichever is the least, the less, whether it's the copay or what they're on the sliding fee scale. So that's for Title X. So again, it just depends on the program as to how you do it. But typically in the private sector, you would have to charge because you're under an agreement and, you know, because you're contracted and also the patient agrees that they're responsible for that, a dollar amount. But there are times that a patient, there's hardships that aren't taken into consideration. Maybe they have a death in the family, or I don't know, just other cancer or something that's caused them that they, even if they're on that fee scale, there's other contributory things that can cause them to be, okay, it's a hardship. And a good way to do it is to have a form that they fill out and they check, you know, you check saying, or write in exactly, just document why the reason why that patient was given a discount or written off for what you see. With the payer, if you have a not putting the sliding fee scale in. Now we get into reproductive health. So this is a cover letter that we have for the reproductive health guidelines. Again, we have a hyperlink to be able to access it. preventative service website. This gives all the coding guidelines when you go to those websites. This is something that came out last year, and I think most of you have seen it, that if you have reproductive health, these are the new guidelines for health choice for the Medicaid MCOs. Did everybody see this? It has the fact sheets with it. I'll scan through it. This is really came out last June. This fact sheet's about the self-referral provisions for health choice members, family planning services, Maryland Family Planning Waiver Program, long-acting reversible, the LARCs, permanent sterilizations, abortions, and OBGYN services. So when you go into the detail with here, with this, and I also have this in the resources, it goes into third-party insurance, crossover claims. Here's some websites, and at the very next part here, this is fact sheet number 1. This goes into about the self-referral provisions for health choice members, meaning with self-referral, you do not have to participate with the MCO in order to get paid for these services. And in the family planning, billing the MCOs, this goes into all those details for family planning. And this is great that this got updated. Any questions about?
I just want to comment that it's not in the agreement for the expert that is not included under the self-referred services.
What she was saying is experts not included in the self-referral. Okay, we do have expert, another folder for that, but that isn't included in that as self-referral. The thing is with the self-referral, not all services are covered. School-based health wellness centers, HIV programs, there's a lot of things that aren't covered if you're not contracted. So the self-referral is great if you're not contracted and you can get some revenue come in, but it's not the best way to go. The best way to go is to be contracted. It just makes it a lot easier and smoother to be able to get paid. And this is more information about the Maryland Title 10 program. Most of you have probably seen this, the application process, all the legal monitoring. And this is something I'm sure most of you are familiar with too, is the purple and white card, people that have family planning services, but maybe not the rest, not full Medicaid. I sure.
So I have a question, action plan. What if we are action plan? We're ready to get this updated our within this manual other really knowing who that happens around, but yes, why together or honestly, I want to say yes. I think that there is a lot of good information here when you look at some of the resources, and we can go through it a little bit after the fact, you know, but as I was going through here, I was really impressed with how detailed in some of these sections, the detail of information on what codes to use for this, when to use this, if you are billing for, you know, an IUD insertion, is it just an IUD, is it an E&M, is it this, is it that? So I think this manual gives you a lot of really step-by-step information on how, when, you know, to bill things. If you've got specific things, we can, you know, after the fact, we can kind of go through them, but I think if you look at the specific area in the specific folder that you're looking for, again, here in women's health, reproductive health, and the STIs, there's a lot of information like that. You've just kind of got to search through it, but it does give you in a couple of the folders where they had the billing manual, some step-by-step, you know, here's the E&M code or an E&M code with the injection, with the modifier,
with, you know, the procedure. It does spell it out pretty well for you. If something's not there that you're looking for, let me know. And again, if you leave here and you are looking at this and it doesn't give you scenarios that you are interested in, let us know as well, because I can get back to you and kind of give you examples of what you should do if you give me the scenario of how something should be built.
Yeah, here's a prime example. Depo-provera seemed to be a big problem with reproductive health. And so what we did was we did a single sheet just showing about the code and making sure how many units that you build for with that. Because we were finding everybody was building 1 unit, and it's usually 150 units. So that was a problem. Charlotte, would you mind telling them, in case there's anybody here that's not in your group, that what you're doing? Because I think it's wonderful, the resources that you're pulling together. She's from Baltimore City Health Department.
Hi. Some of you so what we did is I call y'all need a lot of help around this. Typical operating guidelines, and this is how the board of this. So, this is started using phone calls. Really, you know, we're talking about really how we're having a building work. Now, I have some people that help out that though. And trying to like oh wow, you actually so over the last now so being by the fall but it really works the way of trying to share what that so that's sometimes we're talking about putting out that area is that we are that expansion that covered very cool. Well, then there, but we're getting so many files because of the conversation that come up contact. So little things like this, just creating, trying to do this work that us creating find ways of trying not to call it resistance, but challenge to then have this type of meeting, then put it on a larger pressure. How are we going to technology? How are we going to navigate people? And then at that time. So, like I said, a little bit more informal. I'm going to have everybody behind me.
Thank you. I think that's very helpful. So if anybody wants to get more information, Charlotte has it. But no, I think, you know, kind of pulling your resources together is the best way to go with any of this billing, because you can start seeing patterns, and you think your health department is the only one that's starting to have these issues with an NCO or with a payer, and it may be that everybody's having that problem. I guess the prime one was like when United Healthcare decided all of a sudden a year ago they wanted to have an ET modifier in all your in-house labs, like your urine sticks and hemoglobins and things like that, in order to pay. They weren't paying. A lot of the health departments don't have resources to do all these phone calls, or there's not enough of incidences where they've seen it that they can identify patterns. But, you know, when you find out, okay, well, now they want this ET modifier. None of the other payers do what they do. Once they start doing that, then they can get paid for those labs, which can start ending up being, you know, it can add up to quite a bit of chunk of change you're missing. So, so to move on, so there's information about the depot. Here's again about the time-based coding, because again, you may be doing a lot of teaching in your reproductive health. You may want to have it on time-based rather than on review of systems. This is another one that we've seen a lot of problems with. Can you hear me all right? Okay.
Kind of going in and out.
It's going in and out anyway. I still in LA and CR, we were also noticing that people, you know, usually get 1.2 million units or 2.4 million units. They have an SBI. We can bring this in reproductive health. Sometimes SBIs are handled in reproductive health. But, and again, the right amount of units were being reached. Okay, so this sheet is saying, okay, if you're doing a bifill in LA or CR and you do 1.24, or you're doing 2.4 and you need to do 12 units, again, just an awareness of some of the catches, you know, things that have caused people not to get full reimbursement. These are HIPAA codes with contraceptives, IUDs, and some of the changes they had. This is about the insertions, and it seems to be a big problem that
These are codes that have a tendency to change. So these are ones that you should really keep on top of. Check those on a regular basis. The Mirena, the Nexaplon, you know, every couple of years, those are changing. I see it all the time where, again, these aren't updated. People are getting denials. You know, you just have to be on top of it. So make sure that you are looking at your reimbursement, making sure you are getting paid, you know, what you should be getting paid for these insertions and for the product. But again, these are high dollar codes. Make sure that you're checking those on a regular basis, that you're following up on those, and that you're using all the most up-to-date codes for this.
Again, this is a hyperlink. This is on ACOG, and it gives you information about this, but also while you're in there, you know, about this particular, you know, the IUD. But you can also toggle around to some of these other, when they come up with new items. That's one reason, again, we wanted to use the hyperlink so that you could be able to have access to. There are some of these sites that you may not even were aware of that have free information for you. So take advantage of it and talk around. This is a little bit about the LARCs. Questions, there's a lot of questions about LARC. Here's the billing, here's the codes. Now this does have the B codes, which obviously are ICD-9, but some of this information is still valuable. This is something I found recently online, and it's what makes a family cleaning patient. Now some of our community cook centers, SPHC or whatever, they're not sure whether they qualify as family cleaning or whether it qualifies as a PI patient. So this grid is really very helpful in providing that information when you're screening people if you're in doubt as to what their age is, as to they have children or not, you know, if they have insurance or not. This is a really nice way to be able to go through and screen patients if you're offering more than one service in that clinic. This is, again, ICD-10. This is changes for 2017. This is the ICD-10, the research that I was talking about. You can go on, you can do your search, you can look and see if you don't have a practice, getting to that resource, this resource will. It's a very easy tool.
It's a very easy tool. It's a very good resource. For those of you that I may have done ICD-10 training with at the time, I was recommending to everyone to use the United Healthcare tool. That tool now is requiring you to log on, be a member, so it's not as accessible. That was a good tool. The only problem with that tool is you couldn't type in the description. You had to have the ICD-9 code, and then it would break it down for you to the ICD-10. Right now, this is what we're recommending to everyone. So if you need to look up an ICD-10 code, you can do this by converting 9 to 10. You can do it by just typing in the description or typing in the truncated ICD-10 code, and it will expand for you, giving you, the breakdown for ICD-10. So this is a very good site as well.
And here's the ICD-10 billing, the charges, billing and collections information, guidelines. Again, this is another quick link to the resource. This is another one I found very, very helpful with the revenue cycle management family planning program. Another tool. You're going to find so much billing information even within each one of these documents. This is upstream. This is another one. This is 2015 coding. This is the National Family Training website. This is a very interactive tool when you go on here that you can go through the different steps of training. This is to create a super bill. This tool is if you want to create your own super bill. I think most of the health departments are giving samples, but this is a tool that was put out that you could actually go in here and start toggling around and create your own. It tells you how to do that. Again, we just thought it might be something somebody might be interested in. We wanted that as a resource for you. Now this is family planning and CCU collections. We do a whole section when it comes to the revenue cycle about collections and CCU. This is what the guidelines are that it pertains to. There is the manual for the CCU is 2009. They are updating it by the end of the year. It should be updated probably on Charlotte. Yeah. Right. Okay. When did they update it? Because I didn't. Okay. Yeah. Yeah, I did a presentation in September in Philly for NICRA, and they didn't mention anything about that. But, okay, thank you. We will look and we will put that in before we have to post this new version. And then again, this is just an overview of the Title 10. And this is verifying the Title 10, the income. So this goes, talks about the challenges that we were talking about earlier, whether, the fee scaling, because there are the different fee scaling than what you would have on the normal DHMH or the federal fee scaling. It tells you how to talk to patients. This has got a lot of valuable information also. This is about confidential communications. I think most people realize that with the confidential, if they don't want to use their insurance, they don't have to. They consider going to self-pay status if they're family planning or STI services. The state of Maryland a couple of years ago put a policy in place that the patients could request that if they did go through their insurance company, that the EOB would come back to their home. But it's not a very solid legislation because the payer may choose not to do that, or it could get miscommunicated. The notice that they send to the payer may not really be connected with the claim, and EOB may go back to the home. So there hasn't been a lot of attention given to what most people are even comfortable with trying to do this. But there is an option. They did address it with the state a couple years ago. This is something I add update. This just got updated. This is the Maryland State Family Planning the Program Review Tool. This is a great tool to see if your program is up to all the requirements. And this is what they do when they come out to audit you. It gives you this whole grid so that you can see whether you've met your requirements to fulfill for Title 10. And again, this is more information about 340B. And again, this is your 340B assessment to see if you're in compliance also. That's the grid like we had in the HIV. Here's Cardia's. Grid. Their information, their information is excellent. And I went and checked again yesterday. They are going to have a special manual just for reproductive health family planning, but they still have it up yet for 2017. This is a sample super bill that we do have in there for you, just like we did for HIV. And then this folder here has a lot more information about Title 10. And the review tool. And I think with that, we probably should take a break. Does anybody have any questions about the reproductive health? Okay, the bathrooms are right out here to the right. If you go straight across, that's where they have vending machines. We'll take a 15-minute break. Any questions? Okay, so this is the cover page for the SCI program chapter. And as you know, a lot of, some of the items are on the non-chargeable list, which is the HIV/AIDS counseling and testing. You can't hear me? Okay. I'll try this again. See if it works. Okay, we're talking about STI services now. This is the what's on the non-chargeable list. Some of the programs, like we said earlier, have the combined HIV/STI services together. HIV and AIDS testing and counseling are not covered. They're on the non-chargeable list. STI diagnosis and treatments for individuals under 21 years of age is on the non-chargeable list at this time. STI outreach and infectious disease testing is also on the non-chargeable list at this time. This part over here is some questions and answers. How do I charge a patient that requests their services to be confidential? The answer is the patient should provide proof of income. Financial responsibility should be based on sliding fee scale. And then these are some of the required documents. Pay stubs, tax records, unemployment, award earnings, et cetera, et cetera. So if a patient has insurance and they have a balance, if their insurance process their claim, do we have to bill the patient or can we write off the balance? That's why I wanted to read the sheet. Patient has to be billed. The LHD should establish a policy and procedure on how they will handle hardship accounts. Adjustments for hardships must be based on a case-by-case basis. Does the LHD have to see patients residing outside their county? These are things we asked the AG's office when we were doing the manual. And, you know, he said as a placeholder, we're waiting to hear from the AG's office as to whether they have to or not. We know some counties, especially the ones that are in metropolitan DC area, people cross the lines and go. Some of the LHDs will see the patients, and some of them say they have to be county residents. So that's something you'll have to check within your own health department. So the LHD have to provide services outside their state, and that was something also. I think a lot has to depend on funding. If it's federal funding or if it's state funding, how that works. Again, that's something you'll have to check with your individual health department in your county. Question, a patient came to our STI clinic for a screening and was tested positive for chlamydia. Their insurance company applied the charges toward the patient's deductible. Doesn't the Affordable Care Act state that the patient does not have a copay or deductible for preventative services? Now, the patient came for a screening, and yet they turned around and they had something wrong with them. This is something we've come up with a lot of the clinics, and that's the reason why we wanted to address it also. The patient comes in for a screening, it's covered on the Affordable Care Act with no copays or deductible. But if it turns into having a medical problem, then it becomes a medical problem and not a screening any longer.
So typically, you know, when patients come in for screening, they usually don't come in for screening just out of the blue. There's always a reason why they came in for screening. So, you know, maybe they have a discharge, maybe something's positive, and that's what happens. That's in those cases. So they're coming into the screening itself, and if they're just billed with the diagnosis code as a screening, then those are covered under the ACA. If then during the exam there is a positive finding, there is an acute issue, you know, whatever that might be, male, female, then that does get that E&M code, that diagnosis, that puts that towards the patient's deductible, and that's when the patient goes outside of the ACA, and then, you know, if the patient has a deductible or whatever other requirements they have to meet for their health insurance.
The next question we asked the AG's office is if the patient's 21 years old, they come into the STI clinic and they have insurance, can we bill their insurance? And he said no, that the individual is under 21 years of age and they are on the non-chargeable list. Okay. Now these are questions that we sent to MHO. Who's considered a contact? This is another big issue that's come up a lot with the health department. A contact is from MHO, a partner of a person that came into the LHD for screening and treatment, a person that the DIS notifies contacts STI outreach to let them know that they've been exposed to an STI. Anyone who comes into the LHD saying the partner tested positive for the STI, treat at no charge. Contacts of the STI patient, anyone coming into the LHD clinic saying they had a sexual relationship with someone diagnosed with an STI, could be a patient from your clinic, DIS worker referred them, or another local provider of LHD, and so that those would be all considered outreach patients. What do STI outreach and infectious disease testing mean on the non-chargeable list? Please provide an example. MHO answered routine testing, including CG and CT via urine, Hep B, Hep C, PR, RPR, and HIV blood work includes anything related to a diagnosed case of TB, such as LFTs or TB screening tests for high-risk individuals. For other communicable disease testing done as recommended by DHMH. For many tests are done at no charge. The LHD has to call the lab first for approval. Sometimes they do tests that doctors are unable to do in their offices because of specific collection kits are unavailable. That makes sense, everybody? These are questions that we got a lot when we were starting to do the main one. That's why we presented things to the AG's office and also the MHO. So the STI outreach mean the STI testing is done in a non-traditional venue, such as a mobile health van, health fair, college campus, or elsewhere. The answer is STI testing is done in a center, college, library, HIV testing that the LHD completes, any events the LHD conducts outside the LHD clinic used for outreach testing. Okay. Again, here's another resource for setting the stage for third-party billing with STI services. Hyperlink. Now there is a full guide for billing and billing and downloading. Here again, we go into time-based billing, coding. You'll see some of these repeated in several places again because you may only be focused on STI or HIV again or some of the other areas. And you don't want to have to toggle back and forth searching for documents. This is a STI HIV super bill example. Again, with all the codes. Just to let you know, on these we basically only have the CPT codes. We didn't go into ICD-10 codes. There's just too many of them, and most of you do have those resources available anyway. Another example of Superbill, we had a couple different ones. Here's Cardio talking about their billing code. This is HIV and STI again. This is just a chart on STI transmitted disease tracing. Again, we thought this might be helpful because of the contacts that identify when it's considered a contact. This is information about Medicare coverage for STI services. You do have older people that come into the all clinics also. Here's the and here's an outline of who's eligible, how they pay it. Medicare Part B and screening. MLN Matters is something, a publication that Medicare puts out on a regular basis, and within these newsletters, they often have really pretty good information. You can actually go online and do a search to find if there's updated information. And this is talking about STIs, hepatitis B, etc. Did you want to say anything about it?
The only thing I was going to say about these are great resources, and if you're not signed up for them, make sure that somebody in your health department is signed up on a regular basis, not just with Medicare, but all of the payers that you participate. Make sure that you're signed up to get their regular newsletters, their bulletins, because as Chris was mentioning earlier, United Healthcare, their MCO, now they're saying you have to do the modifier, the EC modifier within health. Not that you'll pick all of that up, because you get tons of emails and it's hard to read everything. But typically if somebody is signed up to be the go-to person or the information person to get these emails and just scan through them, sometimes they come monthly, sometimes they come quarterly, but you'll see the updates for that payer. They'll let you know what's going on, what new codes are coming out, what new policies that they have. So not only Medicare, but all the payers. So, I always recommend have somebody be that go-to person, that person who receives all the information from the payer. So if you haven't signed up, I highly recommend that you do.
This is information expedited partner therapy. There's been a lot of conversation about that. I'm sure that most of the health departments, if you don't know what it is, basically if someone comes in and they have an STI, they can write a prescription provider can write a prescription for their partner to be treated. So there's been a lot of controversy over it, as because the provider doesn't actually see that person. Do you want to talk about the billing? Because you can't bill for talking about the other patient. This has come up with some of the health departments quite a bit.
So, I'm sorry.
When you can't bill, the clinician cannot bill for writing the prescription for the other partner when you're writing a prescription for an STI.
No, it's only for the person that they are seeing and is there with them for the face-to-face contact. So, yeah, you can't, you can, if you're writing a prescription for, they're writing a prescription for the person that's there with you, then, it's that's part of your E&M visit and adds to the complexity of that visit. But you can't bill a non-face-to-face visit or any other type of visit for writing a prescription for somebody who is not there with you,
Does that make sense? Does everybody, okay, just to know whether everybody had heard about this or not, but I know some of the pharmacists didn't want to fill things either. They were not happy with, content with it either. But there's more information about EPT, State of Maryland, another 340B. This is for the HIV testing. And then we have another whole folder in confidentiality, just like we did with the reproductive health. This talks about Title 10, which also, some of the STI, again, are part of the STI program. Okay. It has 14 pages. There's background, again, more detailed information. Here's a Senate bill talking about confidentiality, what we talked about earlier about that form that patients can fill out. That's actually the chapter on it. This is again the consent form to waive from your insurance company sending EOB to your home. This is again just additional information. This is March 2017, so it's an updated document. There's more information, state law, if it goes into state laws, you can look up at that website. And the American Academy of Pediatrics, there's some guidance also about EOBs going back to the home. Is there any questions about the STI? Yes.
My question is, client is referred from a private provider who represents their eye and our and we get credit. Is that not helpful?
We can do an outreach.
No, but it looks like on one of those
You can't do-
articles, it's like refers to the local health department, their diagnosis services.
Right. Well, you can't charge for the testing. You get that, infectious disease testing at this point. I'd have to look again into that. Okay, let me see if I can find out.
You can't charge for testing.
That's on the infectious disease testing is on the non-chargeable list. Then right now you can't charge for it.
What's the point of going for?
Well, you can do it for their E&M service.
Yeah, you're not going for the lab test,
No.
but you're coming in because you're going to have a discussion, you're going to have an EM visit.
Right.
Maybe through your titers or something.
Right. So the visit itself, unless they're confidential, which you do on a sliding fee scale, the only thing they're saying is outreach if you're having somebody come in to, to be treated because, their partner was. You can't charge for that. Okay, it's really muddy. I'll pull that back up in a few minutes or in the break, and we'll look at it again, because that was what Macho sent back about that, right? There's so many scenarios. Right, right. Especially when people come in, and depending on what program they're in, is which sliding fee scale you put them under. You know, whether it's Title 10 or what. In some of it's very confusing. And a lot of times your front desk people, you just hire and you train them. And once you get into more of the payer-specific information, it gets really complicated as to what you need to obtain, and also with the billing. That's why some of the more robust practice management systems, you can put rules in them saying, okay, well, United actually have this modifier with these particular codes. If it's Medicare and if patient's Medicare, then we can't bill this code, we have to use the G code, you know, but there's ways to do crossovers in a lot of the software programs. That's another reason why IT support, whether it's, you know, IT or whether you use software support, somebody needs to be a super user. You need a couple of them either in the clinic or within the health department itself. So as these things come up, they can be changed and updated. Because like we were talking earlier about the super bill, you can update your super bill, but sometimes it's not easy or you don't have the rights to update it. So what are your channels to go through to make sure that that right code gets updated in the computer and the old one gets deactivated, not you know, eliminated, but deactivated. So those are all operational issues within each health department, which is different on how you can do that. Okay, now we go into immunization. I have a whole separate subfolder for VFC vaccine, and we'll go into that in a minute. But with Medicaid expansion, at one time the immunizations were covered for adults. You know, children have VFC vaccine if they qualify because they're uninsured or underinsured or, you know, different factors, or if they're an MCO or Medicaid. But for your regular patients that come in that need immunizations, if they don't have Medicaid and you're paying for the vaccine, obviously you're going to want to charge for the vaccine. You can not only charge for the vaccine, but you can also charge for administering the vaccine. And there are specific codes for doing that. The most common thing that we see in the health department, obviously, is the VFC vaccines. Those are also given at some of the school-based wellness centers. This is just the requirements for the VFC. The adult Medicaid MCO patient, like I said, you would bill the MCO for the vaccine itself, but they do not recognize the administration codes, the 90471, 90472, etc., for giving the vaccine. So what happens when we talk to DHMH about it, they mention that, well, it's always, it gets billed, the administration is rolled up into the visit. There is no visit sometimes during an immunization clinic. If it's an established patient, you could bill a 99211. We were told by DHMH, you could bill a 99211 if they've been in before for the vaccine along with the vaccine charging, because you're only really charging the acquisition charge for the vaccine. You can't charge anything else. Yes? Oh, okay. So this has been quite a dilemma for people that are offering adult vaccines or vaccines to anyone of 19 years and above that they're self-pay. The only reason vaccine would be on the non-chargeable list if it's emergency preparedness at this time. These are the codes for the commercial payers that you would do the 90471 through 90474 for administration. And we have that on the sample super bill here too, which is saying you've given them one vaccine or you've given them two vaccines. We will emphasize that the vaccine codes change too, just like the vaccines do. So making sure also there are several vaccines that are very similar. So if you give a DT and you're using the DT CPT code whenever you get a DTaP, then you're not going to get reimbursed at the fullest rate. Did you have any comment?
The only other thing I was going to say is all vaccines require NDC codes, and to make sure that your system, you know, whether you're changing manufacturer or you're changing code or they update a vaccine, you need to make sure that you are updating your NDC codes as well, because they go hand in hand together. So you will see denials come back if you don't have, one, if you don't have the right NDC code, two, if you have it in there incorrectly, or, you know, again, you change products and everything's completely different. So make sure that you're aware of the NDC codes as you are changing vaccine codes.
Yeah, the same vaccine code may have four different NDC numbers because it's based on the manufacturer, it's based on what the vaccine is, and it's also based on the packaging. So if you get a single dose vial, you'll have one NDC number, where if you're getting a multi-vial, you know, it will be a different NDC. So typically in a lot of the practice management systems, it depends on whether you're married up with your inventory system and you have that plugged in so that you can pull the right NDC, or if you have a drop-down so that the providers or whoever's administering the vaccine can actually check the right NDC number that's appropriate. I've seen claims get denied because they had the wrong NDC number with the particular vaccine, and like VFC says, well, we don't use that manufacturer, so it's not correct. So you want to, again, avoid that. Plus, your practice management system and your inventory, if you can correlate those together, then that definitely helps you to be more compliant. And we know most of the health departments are all compliant with Immunet, putting everything in there. So you do want to report it correctly that way too. And here's where, you know, in your commercial payers, you do not build a 99211. You build the administration code. And as of 2012, the reimbursement for VFC administration is $23.28. So even though you don't get paid for the vaccine, because the vaccine is free, you get paid for administering it. This is a little bit, it's just a chart, again, explaining about billing the different VFC vaccines or purchase vaccines. Kind of hard to read it here, but it should be a very helpful tool for you. This is a list of vaccine names, and they have the NDC names codes right here beside it. This also tells you the amount of units that you would have. In the pediatrics, if you were to purchase pediatric vaccines and not use the VFC vaccine, you can, in relationship to a visit, you can charge components. So if you give it MMR, you have 3 components, measles, mumps, and rubella, and you would charge a code with that to be reimbursed for each one of those administrations of that vaccine. So details about getting into that is in the manual. We don't want to get a lot of detail because most of you aren't doing purchasing vaccine, you're only doing VFC. But the information's here if you need to know how many components are in each one. This is a pediatric easy code sheet. So this not only has about vaccines in it, the most common ones, it also gives you some of the preventative. We know some of the health departments doing WIC and some of the and also school-based health centers. So this information is also helpful with coding. This is just another tool that you could print out and laminate. Fortunately, with vaccines, unless you're doing it for an exposure reason, if the only ICD code you're going to need with ICD-10 is going to be Z23, so it makes it really easy. This is the most commonly used pediatric vaccines. Again, here's the CPT code, here's the description, the manufacturer, and the vaccine component. That is updated regularly. Information is there on that grid. Here's another one for coding for vaccines. Here's a Z23. And this is a sheet similar to the pediatric one, but this is for adults. This is billing the E&M preventative visits and also for vaccines, most common. This is the influenza. Now, this usually gets posted like in October, September, October with codes, because sometimes the codes do change for the influenza vaccine. So this happens to be the one that was 2016 to 17. So September, October, there'll be a new one that comes out to tell you what vaccines are there and what codes they are. And this is where you can obtain the updated. I just have to keep looking for it. And then those codes would have to be implemented, put into your practice management system so people can code for those correctly. The reason why I included this is OBGYN, but this is again immunization coding, and billing for patients that may come in, reproductive health, about reimbursement, about coding for them. It's just another resource tool that was really pretty informative. So we included that. Here's the vaccine administration and pediatric codes again, broken down a little bit differently, saying like the 90472 is an add-on code, it's not a standalone code, and what that means is you can never bill a 90472 without billing a 90471 first. And you'll see that in a lot of the coding, right, Denise? There are other things that when they call add-on code, that means it can't be billed as a standalone. This is another example. If you're billing outside of the immunization clinic, some of the reproductive health and STI may do immunizations in their clinics rather than doing it in the immunization clinic, especially hepatitis B. So this is why we included this, and these are the most common ones. So when you're billing with the 90471, 90472 with the visit, you often have to use a 25 modifier.
You do have to use a 25 modifier, and glad Chris just brought that up. You will find, and another reason is a good reason to sign up to these payer alerts in their newsletters, because they will tell you how to specifically bill something. A primary example is the slide that Chris just showed, where it had a preventative visit with a 25 modifier. Well, coding guidelines are that the 25 modifier only goes on the E&M visit, which is your level 1 through 4. A 25 modifier from coding guidelines doesn't go on a preventative visit. Well, some of the payers have come out and said, if you want to be paid for that vaccine along with the preventative visit, you need to put the 25 modifier on the preventative code. Now, again, it goes against all coding guidelines, documentation guidelines, okay, but payers make their own rules. So if the payer says, like United Healthcare says, if you want paid for a vaccine when you're doing a preventative visit, you need to put on the 25 modifier. The only way that you would know this is that if you get the denial for the claim, or if you read their newsletters that come out and say, this is what we now require. So as you can see, that last slide, it does show put on the 25 modifier when you are billing the vaccines if you want to make sure that you're going to get paid. And again, just to reiterate, make sure that you sign up to find out these little nuances for each of the payers, coding and billing requirements.
And that's where your billing will be, instrumental in giving feedback to you on what's being paid and what's not. And if it's not getting paid, they need not to just it off and believe that the insurance company's right, but they need to go in there and really find out what is the pattern. And that's why when Charlotte was talking earlier about networking amongst each other with the health departments, it's really important because then you can start seeing patterns. A few months ago, there was a couple of health departments I was working with, and immunizations in their immunization clinic was getting paid. It wasn't any problem. Then all of a sudden, they stopped getting paid in the one clinic. And it was because immunizations are in the clinics are not self-referral services. They pay them in the schools because it's self, but they weren't paying it in the clinic itself. So the NCOs kind of wised up about it and started to stop paying. So of course they needed to be contracted. So they changed the rules. This is again another link on how to find appropriate CPT codes. Just click on here and you can, again, get updated on what the new vaccines and codes are. This is a little information about the standing orders. You know, it's come up a couple times within the health departments about standing orders. It's just explained about the standing orders for immunizations. It's perfectly fine. Most health departments are billing under their health officer or deputy health officer, or whoever's written the standing orders when it comes to the immunization clinic. And then here's another article about using standing orders for vaccines. So if you have any concerns about that, you can read those articles. Here's some information on Immunet. As you realize that at the beginning of the year, a lot of private practices were not using Immunet even though they were supposed to with BFC. So it became law that they have to. Part of the reason why the private practices weren't using Immunet is because the same problems that you face. You know, they've got to put it in their practice management system. It didn't interface with the Immunet, so it's double entry for them. So now, you know, hopefully the Immunet will be more up to date, but with what people have, the patients have vaccines. But this is a little bit of the information about the new rules as of last year. Now this is more information about VFC. If I can get it open. I think everybody's pretty well versed on the VFC vaccine, what they are. It's federally and state funded vaccines that are provided for free. They have a lot of regulations with inventory, control with the cold chain, et cetera, et cetera. But basically the thing you need to know is that people meet the criteria, children meet the criteria 19 years, under 19 years, and they're Medicaid eligible, uninsured, American Indian or Alaskan Native or uninsured, underinsured, meaning they don't have coverage for vaccines. They're entitled to be able to get VFC vaccines, which are provided for free. This document kind of shows, you know, what underinsured means. And there's so many different regulations involved around the inventory and all with VFC. But for you, for billing purposes, all you need to do is put the vaccine code and an SE modifier. The SE modifier is not paying for the vaccine itself, it's paying for you administering the vaccine. And you will get $23.28 from the payers if you're contracted for that, from the NCOs. If you're billing private insurance, because it's not a VFC vaccine, again, that's when you use those other vaccine administration codes. That's why we broke out the VFC separate from the other, you know, had a separate subcategory so that you would be able to see how different it is and not getting confused. So this is a section of the billing manual from Medicaid, and here you'll show an example of the code with the SE modifier. Now this is updated in 2015, but obviously some of the codes have changed because there's new vaccines. This is a copy of what the VFC vaccine inventory form is. What's nice about this is they do give you the NDC numbers associated with those. So here you have the out-of-cell syringes, and you have one NDC number. Here you have the vials with a different NDC number. But at least by this guide, depending on what you get, you set up your inventory, you'll know what NDC number is appropriate. There's no way for your biller to know which one you're doing, you know, which NDC. If you have multiple, that's why it's important for the provider who is administering the vaccine to make sure they're clear as to which NDC code they're using. And this is the rule about being effective about everybody having to report an Immunet. This is the patient eligibility screening record that you can, you know, just say why your patient was eligible because of one of those criteria they met. This is Immunet facts again. And this is your responsibility for screening for VFC vaccines. Again, more commonly used vaccines. This is what Denise was talking about with the NDC number goes up in this part of the paper claim. Probably can't see it very well. You'll be able to see it in the manual, but it shows you exactly where the placement goes. And this is the update, and our group soon has these regular updates too. This is the E&M management codes and vaccine for children, the rates this goes into. Again, we have the hyperlinks. If you have any questions, you can go right into it. More about them. EFC, primary care, vaccine information sheets. I know you're all familiar with the VIS sheets, which is part of the criteria that's required for getting immunization. And this is how Medicaid and the VFC work together. Any questions about immunization?
Okay, so this is a scenario. The part that automatically goes through with the child, so we're not knowing, I'm assuming that kids start again for the vaccine, but I potentially because
You can charge for, not for the vaccine because you haven't purchased the vaccine. You can charge for administering it depending on who you're billing, whether you're billing a commercial payer. Medicaid doesn't accept the administration code. You'd have to bill 99211 or the office visit code, and it would be inclusive in that. Right. You leave it.
So are you doing the vaccine during an already scheduled visit, or are they just coming in straight for the vaccine? So if they're coming in only for the vaccine, then you can bill a level 1 nurse visit.
Right.
And that's it. Okay, that's it. If they're there and you're doing another office visit and you happen to give the vaccine during that office visit, then the administration is rolled up into that office visit and you wouldn't bill anything.
Any other questions? Okay. Now we're going to the school-based health centers. I did a revenue cycle workshop last week with school-based health and for their national conference, or their annual conference. And the biggest thing with school-based centers is that they are self-referral services for a lot of things that they can do. Not everything, but a lot of them. Certain things are school nurses, so they have very strict guidelines what the school nurse is responsible for, which is the day-to-day things for kids coming in, but what a wellness center is, which they have a nurse practitioner typically, is who they are a PA, and they see the patient. So they can charge a regular E&M service, they can do preventative services, they're all EPSDT certified providers, they can do the vaccines there, they can bill for all those. The biggest problem with the school-based health centers, again, is billing, because a lot of them don't have access to a billing service. A lot of them don't, to a practice management system. So what we did was, this is how many school-based wellness centers are in the different counties, and there's more growing all the time. When you run into school-based health centers that do high school, then you run into problems, some of them do the Title 10, some of them, the reproductive health, STIs and things like that. So, sorry, this thing is not doing well. So again, this is the cover sheet that we have just introducing school-based wellness centers to this chapter. This talks about the guidance on billing requirements for school-based health centers with local health department. They actually have their own, this is updated really in 2016, a portion of it. This is the billing manual for Medicaid for the school-based health centers. So they not only have the general one for billing, but they also have their own particular school-based targeted manual, and it gives them everything from what goes into what box, if they have to use the place of services 03, all the way through billing for a DFC vaccine, and what the, again, they have their own NPI number, and again, what codes that they can bill for. So they have their challenges too. The MCOs know they're self-referral. They don't have to be contracted, but they run into their issues too. They also have to have a sheet sent to the primary care and the MCO within 3 days that explains all of what their services were during the visit. Plus they call parents. So there's a lot of their visits, there's a lot of counseling. Some of it's not as much face-to-face as it's almost like care coordination, which is a problem because they can't bill for care coordination. And the volume of the patients that they see on a daily basis could never support the wellness center being there. So they're really dependent on funding, outside funding from the county, but any revenue that they can get by billing the MCOs, and it's very helpful for them for their revenue stream. This is something that came out from the federal government in December 15, 2014, which is telling the school-based health centers that they free care now. In the old days, they were referring to free care. If you have bill Medicaid or Medicare, you have to bill all the other payers. You have to bill the patient, But with the school-based health centers and some of the things coming up with the Affordable Care Act, the federal government realized that sometimes it's not feasible to have to bill patients, especially not everybody has insurance like they say that they do. So the federal government sent this memo out to take and kind of relieve the pressure about having to bill everyone for if they bill Medicare and Medicaid. Unfortunately, the local health departments weren't always included in this, and that's why they have that Senate bill that allows them to waive certain charges and create waivers, which most health departments have done now, so they can bill school-based health centers without giving a 5-year-old, 6-year-old bill to take home for their services. This is Bright Futures, which is from American Academy of Pediatrics. They have a lot of great tools for anticipatory guidance and EPSDT and how to bill and code. So this is a great tool that can be downloaded. Also, there's 44 pages to this. This is a copy of the sample super bill for school-based health centers and all their services that they have. Another thing that we were seeing often is that a lot of the lab tests that were being done at school-based health centers, the school-based health centers were paying for the lab. So when they did a stat strep or urine diff or something like that, they were paying the lab for the service rather than billing the payers. So if you have a school-based health center and you're doing a LabCorp is the lab of choice for all the MCOs. So make sure that you put that information if you're sending something out to bill for it. And also you can bill the MCOs for it too. You don't have to absorb the costs of the ones that you're doing in-house. But anything that's being outsourced to a lab, they need to bill the insurance company or the MCO, not you, for it. Again, this is time-based coding, which is sometimes very helpful because, again, the nurse practitioner spends hours counseling and talking to the patient or talking to the parent. This is contact information for different school-based health centers. This is a Bright Future. Again, the American Academy of Pediatrics put this out. It's a pocket guide. This is the Maryland school-based PowerPoint presentation that Medicaid put on a couple of years ago, and it's really good because it gives some information about billing O3 modifier and different things like that. So we thought we'd include this in here too because it's a pretty nice slide deck of PowerPoint. And again, here's maybe the children well visit, which is something that definitely school-based health centers could use. There's your immunizations, and this is the form that they're required to fill out. This should be 10, but this is the most updated form they have, that they have to fill out and send in each time they see a patient in their clinic to the primary care and also to the NCO. So there's a lot of paperwork involved in that for them. They also have a lot of problems with enrollment because they have to do that at the beginning of the year with the parents to get consent to treat. So a lot of times the parents aren't forthcoming with the insurance information, or it may change. So they have a lot of denials that way. But with patients that are Medicaid eligible, at least they can call EVS and verify and bill that way. So they have a lot of system problems trying to get paid, just because of the fact that they don't have a parent there. So this is information about the EPSCT manual and how they can bill for that, those services. Is there any question about school-based wellness centers? Is anybody here representing school-based? Do you have any questions? How's your payments coming in? It's coming? Struggling? Are you credentialed with a lot of the provider payers, or are you okay. Right. Yeah, they're a bit of a problem because a lot of them don't understand the whole way it's set up. They don't understand the self-referral process. So when you're talking to somebody who claims, they're not, they just don't get it. You're not contracted. Anybody else have anything? No? Yeah. That's not on the self-referral list. That's a good question. I can look. Again, they're not required if you're not contracted to pay it. Okay, so you'd have to be contracted in order to get that. Right now, I only know that Medicare and Medicaid are the ones that have been allowing it. Have you, Denise? Have you seen it?
No, I haven't seen it anybody but Medicaid.
That's a really good question. I put that down. I'm going to put a note in here to definitely check on that. Because when you get into the high schools, even middle schools, definitely at this point, one of the things with school-based health centers is if you have a child that comes in with and you have Title X program, you have to base the income on what the child makes, not on the parent. So you're doing a sliding fee scale. So basically you're doing it down to zero. Again, that's where it's so difficult to try to get reimbursed or pay for some of these services. And they're definitely, when they have private insurance, they're not going to want an EOB going back to their home or something like that. So most of those would be confidential. Medicaid doesn't ever send an EOB back. So it doesn't matter when it comes to Medicaid. But some people still say, I don't want to even use that. So it makes it really touchy.
What's on the sheet for how many school-based wellness for at each county? Ours is
What county?
one county.
How many do you have? Did you, I got that off the website for the DHMH, this county, how much they have, because I know that there's another, two more also. So it's becoming more and more popular. And they're in areas that people don't have. And a lot of times it's also illegal immigrants, so they're not going to have, Medicaid. So that's one of the other barriers why it's so important that people that do have insurance, that you're able to capture and get the revenue from them that you can't from the other. Does your county have a waiver only to be Medicaid for your one school base?
So,
Okay. That's what I'm seeing the trend, whether you're supposed to or not, but that's what the trend's been. It's like, how do you bill? Some of the health departments, what they've done is send one voucher home with the patient, with the child in an envelope, and say, well, we billed. That's how they've kind of gotten around it. Not that that's right, but that's what some of them are doing to try to figure work around. Yeah, a lot of stuff. You hardly ever did. And you don't want money coming to the schools. So that was another thing. If the billing goes out, you don't want it $5, $10, $20 coming to the school because heaven knows what's going to happen. You certainly don't want to be responsible for it. So if you send it out, typically what we do is put an envelope in there so it would go to the health department, their billing. And that would be the best way to do it. Hepatitis C, there's really not a whole lot to talk about with the hepatitis C, except that these are the codes. If you can't bill for testing, obviously, for infectious disease testing and all, but if you see somebody in a clinic and you're doing hepatitis C, it would be in the STI clinic in most cases. But you can do preventative visits, just like we were talking about earlier. In the end, if you're talking to them about if it's not treatment, it's actually a visit. And here's your expert, your alcohol screening and your expert Medicaid and your preventative counseling codes. Now, a little thing about the preventative counseling codes, those are for commercial payers, 99401 through 99404. Your Medicaid and NCOs don't recognize those codes for the most part.
So if you're going to do counseling for a Medicaid, Medicare patient, that's where the time-based coding really is beneficial for you. In commercial payers, they will allow you these codes, the 99401 to the 403, but those aren't payable for Medicare and Medicaid. So if you're going to do counseling for a patient, use the time-based format and bill an E&M code.
Mm-hmm. You can get some.
We can get some, yeah. Let me look. There are some, and I will get you, off the top of my head, I can't think of what they are, but I will get you a list of.
And we can add that in here before we, send it to DHMH. Here's the authorization form for the treatment. So most of your payers are going to pay for the treatment if you get authorized and send everything in. They handle it all. It's just that you're seeing the patient, but you can do the referrals and all, and they will to authorize treatment. Here's about a treatment plan, just a sample one we included in there. This is the criteria for hepatitis C. These are all DHMH documents. Again, we just thought it would be helpful. Here's some codes here, Denise, but I can't make it any bigger.
The new CPT codes, not the ICD-10 codes.
Right. And we know for the most part there's not a whole lot going on with that, and it may be rolled up into another clinic, but again, we wanted to make sure we had addressed it. Rabies is kind of a thing in its own too. This came up quite a bit. Here's the COMAR regulations about rabies, because there are some things that you can't charge for with the rabies. But if you're giving rabies vaccines and they have insurance, get authorization, and because otherwise some of the counties are sending the patients to the ER. Then the insurance companies are paying the ER a lot more money, even for their subsequent shots that they have to get after they get the initial set. So it came up with Dr. Haff was even looking into it, that some of the health departments weren't getting paid, reimbursed for that, and it's cheaper to go to the health department than it definitely is to go to ER for these payers. So I worked it out, just making sure you have the right diagnosis code, the date of the incident on the claim form, and that you call and get authorization that you're doing these rabies injections and the reason. And for the most part, you should be able to get paid for them. Again, here's a little bit more information about the cases in Maryland. These are pretty short. Here's expert information about that. We have a lot of resources again here. About the reimbursement, the codes, what the fee schedule is, and how much time for each one of those categories. Most of these articles you've probably seen already. But again, it's one place for you to find it. Here's just a little brochure that you can print out and fold. Here's a step-by-step guide for screening and intervening. A little bit more about the program. This is Medicare and expert. And how to code and how to bill for it with them. And more articles. This is screening and intervention again. This is for Medicare. And this is the mayor group. And what their goals are again in their codes that they're using.
I'm scrolling through these as Chris is doing this, looking for diagnosis requirements. I haven't seen anything yet, but I'll get back to you to see what are appropriate. If there are any requirements for diagnosis for this. I'm not seeing anything. As she's doing this, I'm kind of scrolling through and looking at everything, and I'm not really seeing any diagnosis requirements. But I like I said, we'll post that, and we'll, if there are, we'll let you know.
Substance abuse. This wouldn't have that in there either. So, any questions about expert? And again, that's a fairly new screening process that's going through. It's just like school-based health. They can screen for some of these developmental tests and all, they can bill for those to the school wellness center. TB is another one that's on the non-chargeable list. So you can't bill for TB testing or TB treatment. But if you're seeing a visit patient for other things that's not treatment related, you can still bill the E&M codes. Does that make sense? Question? So we've just done a section here showing about the different codes. And here's PPD. Typically, if it comes off the non-chargeable list, and you're able to charge for a PPD test, what you would do is charge for the test, and then when they come back in 3 days to have it read, if you have them come back, then you charge your nurse visit. The nurse is doing a 99211 if you're just having your MA or your nurse read it. That often comes up as to what happens when they come back in 3 days, and it's not included in the actual test itself, the reading isn't. This is a little bit from Medicare about TB testing. Again, we did this section thinking that it may come off the non-chargeable list, so you have the resources on how to code for Medicare and Medicaid. And then this is just the health department TB coordinators. We thought that might be helpful. We don't know what the non-chargeable list is going to be. Every year they talk about reducing it, and I think because the health officers have an option of saying, they don't want to charge for certain things within their county, that may be, that regulation, but we don't know what's coming off. But July 1st is the new fiscal year for the state of Maryland, so every July 1st they say whether they're going to keep the same non-chargeable list or whether they're going to modify it. So if it comes off, we wanted to make sure that any services that you may do within the health department, that we address them to some capacity here, so that you can know and have this as a resource to bill them if you're allowed to bill them if it comes off. Okay, so we're just kind of, yes, prophylactically, you know, looking at the same thing when we get new refugees. Now, behavioral health is a different animal. In some health departments, they outsource their behavioral health, and some are doing methadone clinics within and Suboxone and things like that within it. As I mentioned earlier, as of the 15th of this month, they've done something called rebundling of the way the codes were. A couple of years ago, they started using some mental health codes, age codes, and how they wrap things up together. But now they've changed it again. So this may answer one of your questions. According to the non-chargeable list, following addictive services cannot be billed. Court-based screening, general educational prevention services, in-prison detention center services, so that's staying in the prison. Education prevention provided to adolescents in school setting. And this goes again into, you know, what are diagnosis codes, CPT codes, level 1, level 3, and talks just basically about those codes, and this again about medical record documentation, which is a little bit different when you're talking about behavioral health and mental health with counseling rather than, you know, your regular E&M services. So this is a manual. This has been updated in 2017 with some of it. This is something Denise and I have really been reading a lot of the past couple of weeks. Did you want to make any comments?
Does anyone here, I mean, specifically work with the substance abuse? So as Chris was saying, they're calling this the rebundling initiative, but it's more, if I look at it, it's more of an unbundling initiative. Yeah. And so now that they are allowing additional services, the problem with this is, and what we're finding in the last couple of weeks as this initiative is going into effect, is that, you know, this is all going through the behavioral health and through Beacon, and even though they're implementing this, they still really don't have all the answers. Okay, so what they're doing is they're allowing additional codes, additional services to be performed under the substance abuse program. These services are additional counseling, E&M visits, if the E&M is clinically indicated. What does that mean? Not really sure yet. Okay, so clinically indicated, you know, are these signs, symptoms, withdrawals, you know, issues that the patients are having, you know, due to substance abuse? We're trying to get specific answers, you know, from Beacon, but what the guidelines are now showing is that, again, besides the assessment and the dosing, you can now do the, it's the induction codes, it's the counseling codes plus E&M codes that have been, you know, added to this. The dosing codes, the fees for the dosing have been reduced, but what it does then do, because everything was sort of rolled up in there, it now adds additional services that you can bill on top of that. So if you're providing these services, it has really opened up and is allowing you to actually probably get paid for things that you've been doing, you know, and get a higher reimbursement, even though they're lowering the dosage. So what is still in question is, you know, E&M services that are clinically indicated. So these are all established patient visits, your level 99211 to 215. What are we considering clinically indicated? Are these things that go hand in hand with the substance abuse, the withdrawals, or these other things that while the patients are there, because you may be their only health care that they're receiving, are these other things that you can, you know, treat them for? So we've got some, you know, feelers out to Beacon. We've got some questions that we're trying to get answered, but just know that, you know, this program has expanded, and that now counselors can bill for counseling, aside from the assessment in 15-minute increments, and you can also bill for E&M visits. And it's going to be a trial and error as we go. Yeah.
Are there specific guidelines as to what those can be built together?
Yes.
Here?
That's right on here.
Yes, right.
Read it.
If you'd open it up, you'd probably get a clearer version. There are specific things that can be billed the first week of treatment, the initial week of treatment. Then follow up as you go on. You can't bill an E&M visit the first week of treatment because the first week you're limited to the assessment, and you're also limited to you can do the therapy, which you couldn't do before, and then you get the induction codes. The H00,
No, sorry.
H0016. So they've added a couple codes. Those are what you can bill the first week. You can see those 4 codes, whether it's individual or group therapy, and then the assessment and the induction. After that, you can then bill, as long as you're using they have a new modifier, an HG modifier, which indicates that it's substance abuse program. You can bill again, the maintenance. You can bill E&M codes. So this grid that Chris has created, we got all this information specifically from Beacon, and it outlines what you can and you can't bill. What we're recommending is making sure that, again, as these new codes have been added with any program, when they give you a little bit more free rein and tell you can bill more things, it also opens you up to greater oversight. So what we recommend is if you are billing these codes, making sure that your documentation supports these codes. So your counselors, if they are now if they're billing for counseling services, the H004, H0004. If they're billing in 15-minute increments, make sure their documentation supports that. Make sure that their documentation states that it's face-to-face counseling. Document the content of the counseling and the total time. They definitely want to see start and stop times for these counseling services. So make sure all of that is in your documentation, and that if they ask for documentation, that it supports that. Same thing with your E&M codes. Make sure your documents support E&M services. Counselors cannot bill E&M services. These E&M services can only be billed by a physician, a nurse practitioner, or a physician assistant. If you're billing under a supervising physician, you still need to make sure that you are showing who the rendering physician is, and the rendering physician is signing your documentation as well as the supervising physician. So again, making sure that you are compliant with all of the guidelines, because these are changing, making sure whenever they say, hey, you can do this, they're going to start looking at those things a little bit more closely now. But again, this is a growing period. This just went into effect on May 15th. So, it's going to be a process to see exactly, especially with the E&M codes. I was told by what I'm recommending for those that do substance abuse and are billing E&M codes, that you use that dependency code, whatever code you're using, whether it's the opioid dependency or whatever dependency code diagnosis that you have been using for this treatment. You still use that as your primary diagnosis for the E&M visit, and then whatever the clinically indicated issue may be, their signs, their symptoms, their withdrawals, then that be the secondary and the tertiary diagnosis after that. I think that will help to get the codes paid, hopefully, and to, at least as we go through this process, to make sure what guidelines Beacon is going to set for what can and can't be submitted.
The other thing they've done is change the authorization number of units since they've done this. So anybody that had authorizations in there up the unit amount quite a bit. They figure that they have like 6 to 12, I think, for the E&M services. And
they've got a formula that they're using. You can't find the formula anywhere online, but it should be invisible to everyone, the process of getting these authorizations. You don't have to go in there right now and request additional authorizations. It will automatically just be added to what your existing authorizations. And they say that they are going above and beyond. So if you think worst case scenario, you'll use 20 units, they're going to give you about 50 units. So they're making this above and beyond what you think you're going to need in this period, so everybody is covered. if by some chance you may happen to need additional units and have to, go above that, they will allow you to request more units for authorizations.
Yeah, they're still only good for 6 months, your units are, so you still have to monitor it, and I know you have to go on the Beacon website to do that, but just to let you know, they say they're addressing it. So this like Denise was saying, this gives you the code, it gives you the rate that they're reimbursing, it tells you the units, and this also tells you the combination of services that you can do. This is also that you can charge for the screening, like the expert, it gives that information here with this. You can do it every year, once a year, or you can do it more frequently if there's a change. This is the E&M code and the reimbursement for that. The screen I showed you a few minutes ago was for LHDs, for local health departments. There are different types of provider types, and the reimbursement's the same, but how you code and that type of thing is a little bit differently. We also include, and you'll see in a minute, the counselors, what qualifies for a certified addiction counselor. There's different levels as to which level they need to be signed off with supervision. So that's included in here too. These are just common codes for behavioral health. And there's Medicare on here too. Because what we're talking about was Maryland. Medicaid, Medicare may be different. This is the changes, the memo that came out from DHMH in January regarding the screening. This is a grid on the reimbursement, how much is reimbursed depending on type of counselor for some of your regular mental health services, which is different. Again, this is more information on billing properly for behavioral health. This is a facts and frequently asked questions. So we've included that too, just in case why the regulations needed, how does it impact Medicaid with these new changes. And we have a section here on Beacon, their manual, where they go into detail about how to submit, how to register, credential with them. As you know, Beacon's an ASO, and now everything for Medicaid and Medicare, Medicaid goes through Beacon for their mental health, behavioral health services. And that's where I think that Denise has run in. She's been on the phone a lot with Beacon the last couple of weeks, and they don't understand medical because they're mental health issues, so they can't answer some of her questions.
Yeah.
She's a real frustration.
So if those of you that are dealing with the substance abuse programs, Beacon does have a few webinars, and they are ongoing. And I think that, I've been on a couple of them. Chris said, can't necessarily get all the questions answered. I keep, I want specifics, and I'm not getting specifics. I mean, and the women who are doing them are very helpful and very nice, but they just keep telling me I'm not clinical, so you can't get the answers to those clinical questions. But the webinars are very helpful, and I think that they do have, even if the webinars are done, and I'm not sure what their timeline is to keep going with these webinars, but the slide deck for the webinars are available on their website. So they are very helpful. They're very informative. The slide decks give you a ton of information. And I have to say that, they will email you back. So if you do have questions, related to how to specifically bill something, or you have a certain case scenario, again, I would stay on top of them because, again, I'm not getting a lot of really clinical information, but anything other than that, they have been really good about. So, again, look at the resources on their website. They're very helpful, very useful, and, don't hesitate to email them on something, And again, I think that because this is new, you probably will see some delays in the claims, or maybe even some denials in the claims. It's going to be a work in process. It really is.
Yeah, they spent the weekend before the 15th, 13th and 14th, just updating their software to be able to accommodate the changes, except the E&M codes and things like that. So one of the comments on their listserv was they were having some problems with things being denied, and one of them was the primary diagnosis code wasn't always the opiate addiction code or whatever it would be indicating that. So they haven't been real specific also about other diagnosis codes. Like Denise is saying, it opens up a whole can of worms. They're saying, well, if somebody comes in with addiction, maybe they have a sterile abscess or they have an STI, you know. Where is it limited to where you go and send somebody, or whether you can treat them yourself there? Because it's certainly if you do an IND, that's not an E&M code, you know. So it just opens up a lot of things. One thing that we did find out, STI, Beacon doesn't pay for urine pregnancy test, and they also don't pay for the TB test, which is often seen in the clinics. But your MCOs are supposed to be responsible for paying that, which another level of complication when it comes to with the practice management system. Make sure that you're billing the MCO for the pregnancy test, or you know, obviously the urine test for determination, for screening for drugs is considered part of the treatment, or the dosing if you're dosing for methadone or some of these other medications. But those other tests are not bundled in with it. So just as an FYI, you can still bill, but you have to bill the MCO. So that means your claim's going to different places. So that was it. Okay. This is one of the PowerPoints that Denise is talking about. Really, this is April 12th. This is really a very good one. It does have some great information in it. Like she said, it talks about some of the COMAR regulations that gives you that, so you can actually go right into the site and read the regulations. They actually have the codes and what their reimbursement is going to be. And it even has some of it in here. I know they have the codes in here too. Oh, no, that's not, but it's in here. It's in all these regulations, so easily find it. There's a wealth of information. These other forms, we checked with Beacon because we had read if somebody doesn't have Medicaid and you're doing a sliding fee scale, and they come in, they're self-insured or uninsured, I should say, that you can submit for the funding that's provided by Beacon from the state. You can submit to Beacon to get reimbursed from them. Okay, and there's certain screening criteria for that. So if you have somebody that's uninsured and they're coming in for opiate addiction or some other type of drug addiction, you can actually submit the claim to Beacon. You just have to fill out these forms, which are in the manual also. Does anybody have any questions about that? So this is something new to us. I don't know whether you were aware of it before or not. Yes. Yeah. Okay. I won't open up every one of these forms because you'll be able to see it in there. And this is the ICD-10 updated codes in October showing the replacements. So, we do have those here. Okay, and that's, again, one of the slides in the manual. Any questions? Do you want to take a break, or do you want to keep going? We don't have that much left. I know. This is so dry. I know. And I was thinking, what can we do to make it more entertaining? That's why you have candy and keep you awake, you know.
We just have, there's 3 more and they're either very minor.
Right. This is not, so you want to just go so you can go? Okay.
Anybody need any water?
Yeah, the water candy. Okay. Dental, we haven't really dealt a lot with dental because most of the health departments we've been to are doing quite well with the dental themselves. We put the new dental fee schedule for 2017 in here. A lot of the health departments have their own codes, their own software, separate software is not always integrated with their primary practice management system, and they're doing quite well with reimbursement. So what we did was We haven't done a lot of screening. We just gave some information about the codes and the nomenclature for dental. We have the oral resource book from DHMH. We have the 2017 fee schedule for dental. And this is just a little information because Brian White also helps support for dental. So I wanted to make sure we had that information in here also. But again, not every health department is providing dental either. So that's short. Any questions? Okay. Of course, like we were saying, what we wanted to do was provide you information so you knew how to navigate around through this manual. A refugee, you can't, at this point, you get a funding for the refugee program. So that's all taken care of. So you really don't have to worry about it. But it may come a time in the future that your refugee, you may be billing fee for service. So that's the reason why we wanted to include information here. Most of your refugees, if they're coming legal, they do have Medicaid, but because of the way you're being billed, you're being funded, you're not tapping into the fee for service process at this time. But again, that may change. So this is just going in a little bit about the MCOs. I did contact DHMH, and she gave this information about the refugees, so I thought we'd include it in here because I want to make sure we weren't missing anything. And we'll quickly go. Are refugees eligible? These are questions I posed to her, and these are her answers. Are refugees eligible for Medicaid? Yes, as long as the refugees meet the income requirements, they're eligible. Can the LHD bill Medicaid for refugee health screenings? No. The LHDs are paid a flat fee. The directive we have from the HHS Office of Refugee Resettlement is that their Medicaid is active at the time of the health screening. The health screening should be billed to Medicaid. She said, however, most LHDs are not fully implementing Medicaid, nor do they have the capacity, nor do they have the contracts with the MCOs and Health Choice. So for the health screenings that occur for the LCDs, rather than bill Medicaid, we're providing them with a flat fee reimbursement that is funded through ORR called Refugee Medical Assistance. LHDs cannot receive a flat fee reimbursement and also bill Medicaid for these health screenings. Can LHD bill Medicaid for refugee immunization services, adult immunizations? She said yes. If the LHDs have the adult vaccines in stock, meaning you purchase them. Can you bill for children's immunizations? Yes, a child can receive their immunizations through the VFC program, so you can bill Medicaid for that. Okay? So your other services are all included, but those are some services that you can bill for. This is about the program. This is a super bill that we created, again, with the preventative visits. Even though you can't use it now, the bill is, again, a tool to know that in the future, if they do have you start doing fee for service for the preventative visits and all, these are the codes and all that you would use. And then this is a little bit more information about their user guide for their information for the refugee camp. Any questions? Almost done. Telemedicine. Now, we know some of the counties have telemedicine capabilities with school-based health centers and that type of thing. Up to this point, you haven't been able to bill. And there's just some new regulations and things that have come around the pike that do open up the possibility to be able to bill for telemedicine services. I have not had the opportunity to do a lot of research in it. I have included everything here in the manual about telehealth services. Because if you're the originating site by Medicare, they pay like around $24, $25. Originating site is the site that the patient's at. And then the provider is at the other site, at the other end. Usually there's an audio-visual type of, whether you're using Skype or whether you're using that equipment for the provider to actually see the patient. Psychological issues, we had a clinic that we were doing work for, and they had a woman and child clinic, homeless shelter above, abusive parent, up above their clinic. And so what they had is they had incidents of rape and some pretty heavy stuff. So they had telemedicine set up in their clinic so that if they had a patient come in that really needed to see a psychiatrist, they would have access to a psychiatrist on a pretty regular basis. And they could sit in a room and they could converse, and that way the psychiatrist could actually bill for services. The clinic would only be able to bill for origination services for originating and providing that tool for access. But up to this point, it's been really difficult to see who's going to be able to get permission to be able to be an originating site and the receiver. So those type of things are what they're working out now. But I wanted to include this even though we don't have all the fine details yet.
And it's very payer specific too. So each payer will have different guidelines on your telemedicine and what is allowed and what isn't allowable. Care First, for example, has a new program that they will, they implement, and you go through their portal, the whole video thing that they've set up, so it lets them track what you're doing as well, and you're able to bill services. So every payer is a little different. Again, look at their guidelines, look at what their requirements are for telemedicine. If you meet those requirements to be able to provide those services, but it is making sure there are a couple things involved. Again, are you the originator? Are you the provider of service? And do you, does that payer allow for those services? So again, payer specific, look at your guidelines and look at your provider manuals to see what's required.
Any questions about telemedicine at this point? No? So we pretty much covered everything that we wanted to today in Chapter 4. Are there any questions about any of the other sections of the manual that you'd like to look at while we're here, have questions about, since you're face-to-face? India?
Are they available?
On the manual?
Yeah.
Okay, the first two that we did were on site. This one, hopefully, Sarah was able to get enough information to be able to post this one too. But at this time, Smita, you can address that as far as the future, what they're going to.
Yeah, on the DHMH website, I to request
And the little slip of paper that came on top of your money, your fake money, is to be able to show where you can get access to the manual and to the webinars. But as far as right now, there's no other scheduled events for us for presenting the manual. Okay. And the updates, we don't, they're working out some of that also. I hope this was helpful. I know how we